perfusion releases volume, it will begin to collapse the lung as it expands. Again, some sort of fusion, some sort of pure exudate, anything that takes up volume can collapse the lung. Another type of compression atelectasis that we often see, we see in bedridden patients. Sometimes bedridden patients, they're not ambulating, the diaphragm moves upward and collapses the bases of the lungs, and we see bibasilar atelectasis. This is a type of compression atelectasis. It's caused by the diaphragm simply compressing the lung. Next type of atelectasis we see is called contraction atelectasis. This is usually caused by scarring in the lung. It's also known as cicatrization atelectasis. Typically, there's some sort of scarring in the lung that causes areas of the lung to be compressed, areas of the lung to be stretched. Get these areas of the lung that are compressed, and the area becomes atelectatic. Again, something you see in scarring. Then finally, we have something called microatelectasis. Microatelectasis is generally caused by a deficiency in surfactant. Remember, we talked about the function of surfactant. Surfactant allows for the even inflation of all the alveoli. Typically, it's elaborated by the type 2 pneumocytes. Coats the interior of the alveoli so they can all inflate evenly. If there's a deficiency in surfactant, some alveoli are going to hyperinflate, some alveoli are going to be collapsed or atelectatic. This creates little microscopic patches of atelectatic lung throughout the entire lung parenchyma. And so we call that microatelectasis. This is a type of atelectasis caused by a surfactant deficiency. One of the common scenarios in which we see in surfactant deficiency is in newborns. Some patients born prematurely, newborns born prematurely, they're not making surfactant, one of the last organ tissues to mature properly with the lungs. And when you have a premature child, the lungs really aren't making enough surfactant to keep the lungs relatively expanded. And as a result, they will develop microatelectasis. Let's take a look at an example of lung tissue that is atelectatic in a newborn. This is called atelectasis neonatorum. This is a section through lung. And if you look at this section, you'll notice there's really not much you recognize there as lung. And that's because you're accustomed to seeing the lung fixed in an inflated position, where this lung is collapsed. You don't recognize any alveoli. You don't really recognize any kind of structure that you relate to the pulmonary system. But if you look closely, you'll notice this. Anybody know what this is? What is it?
Pseudostratified.
Pseudostratified ciliated epithelium. That's what that is. You see it right there. That is the pseudostratified ciliated epithelium. That's respiratory epithelium. And that's about the only clue you have here that you're dealing with some pulmonary tissue. If you look a little closer and you're accustomed to seeing collapsed lung tissue, you can recognize these little spaces are actually alveoli. And if you look closely, occasionally you'll see a type 1 pneumocyte right there. And it's lining the entire cavity. That's a collapsed alveolus. This is what atelectatic lung looks like. Atelectatic lung, of course, is not really going to support good gas exchange. And this is the problem sometimes we have with prematurely born infants. Their lungs are just not mature enough to produce surfactant and they become atelectatic. And there are alternative ways that we'll have to use to try to oxygenate the lung and extract CO2. Okay. Sometimes you'll know ahead of time that the child's going to be born prematurely. Okay. If you know ahead of time, there is a way to accelerate the maturation of the lung. Typically, you could use steroid. You give the mother steroid, and the steroid accelerates the maturation of the lung. So if you can keep them on steroid for a week or so, by the time the child is born, their lungs actually will produce enough surfactant to stay patent. But you have to know it in advance in order to give steroid. Okay, any questions on that? Yes.
What do steroids do? How do steroids speed up the process?
They change gene expression, and it just so happens they change gene expression in the types of pneumocytes so that they start synthesizing all of the enzymes necessary for surfactant production. Yes,
So I'm gonna say that I don't know how to say this word, like lactases
atelectasis.
is micro lactases for insufficient sulfate. Or I'm gonna say there is neonatal. Like which one?
Oh, this is an example of microatelectasis. It's called atelectasis neonatorum.
And that's the one without the sulfate.
That's the one without the surfactant.
So the example is not the micro. That you said.
Microatelectasis is generally caused by a surfactant deficiency. So this is an example of microatelectasis caused by a surfactant deficiency. It's called atelectasis neonatorum. It's a specific example of microatelectasis. All right, any questions on that? Let's talk about some major categories of pulmonary disease. Generally, when you have a pulmonary disease, we subclassify them as either chronic, as either obstructive or restricted pulmonary disease. The way we tell the difference between these two diseases is based on spirometric findings. Generally speaking, obstructive pulmonary symptoms is caused by some sort of obstructive airflow in the airways of the lungs. Person generally can inhale, but when they try to exhale, something generally obstructs the outflow of air. Okay. Restrictive lung diseases characterized by some sort of restriction in the ability to expand the lung. There's no obstruction to airflow. They can inhale and exhale okay. The problem is inhaling so they can fully expand their lungs. The lung somehow is restricted in expansion. It can't expand fully. That's called a restrictive lung disease. Let's take a look at some of the main spirometric variables that allow you to tell the difference between obstructive versus restrictive lung disease. There are a couple of important spirometric variables that we have to measure to determine whether the person has obstructive or restrictive lung disease. We talked about some of these different spirometric variables. Let's take a look at some of the normal values. We have the FEV1. This is the forced expiratory volume in the first second. This is a measurement of the volume that you can forcefully exhale in the first second after you fully inspire. So you take a deep breath, and you exhale as forcefully as possible in the first second. The amount of volume that you can forcefully expire in the first second is called the forced expiratory volume 1, or the FEV1. Typically, it's about 4 liters. Okay. We talked about the forced vital capacity. Forced vital capacity is the amount of air that you can forcefully inspire and expire without any kind of time limit. Take a deep breath, expire as much as you can. Okay, that volume that you can move without any kind of time restrictions is about 5 liters. That's the forced vital capacity. Now, typically, the FEV1 is about 80% of what the forced vital capacity is. But very often we measure that by expressing it here as a ratio. The FEV1 over the FVC typically is about 80%, meaning about the FEV1 is approximately 80% of what the forced vital capacity is. Okay, well, these different diseases, obstructive and restrictive diseases, you'll find that many of these spirometric variables are altered. Some of the most important changes in the spirometric variables involve the FEV1 and FVC. Let's take a look at the obstructive pulmonary diseases. Okay? Obstructive pulmonary diseases are so called because there's some sort of obstruction to airflow in the airways. Okay? Inhale, but typically when you try to exhale, there's something that really resists the outflow of air. And so there's an incredible increase in resistance during the expiratory phase. Okay, well, that's going to affect the amount of air that you can forcefully expire in the first second. i.e. it's going to affect the FEV1. And so the most characteristic feature of these obstructive lung diseases is going to be a reduction in the FEV1. Okay? Usually the FVC is fairly normal. The FEV1 or FVC ratio is significantly reduced. If the normal is about 80%, meaning the FEV1 is about 80% of the forced vital capacity, this could be significantly reduced down to 50 or 40%. The most important feature of an obstructive lung disease is the reduced FEV1. Then you got these restrictive lung diseases. And they're called restrictive because something restricts expansion to the lungs. You can breathe in and out, but you just can't fully expand your lungs. Something is restricting the volume of lung expansion. Well, that means there's going to be a significant reduction in the forced vital capacity. And the most characteristic feature of a restrictive lung disease is going to be a reduction in the FVC. The normal FVC is about 5 liters. A person with a restrictive lung disease could have a FVC of only 3 liters or even less. Okay. Very often, these restrictive lung diseases are caused by some sort of scarring in the lung. Scar tissue forms in the lung. It replaces the normal elastic tissue in the lung. It makes the lung nice and compliant, stretchable, extendable. You replace that with scar tissue doesn't stretch very well. And so it becomes very difficult to expand the lungs. And so these restrictive lung diseases are characterized by a reduction in the forced vital capacity. That's the most important characteristic. Now, obviously, if you can't inhale as much air because you have a reduced forced vital capacity, you're not going to be able to blow off as much air in the first second. And sometimes the FEV1 is reduced. However, the reduction in the FEV1 is always in proportion to the reduction of the FVC. And so if you take a look at the FEV1 FVC ratio, it's actually normal, meaning that even though you have a reduced FVC, you can still inhale and blow off about 80% of your FVC, even when you have a restrictive lung disease. So typically, if the FEV1 is reduced, it is only reduced in proportion to the reduction of the FVC. Yes.
So if it stays normal though, the FEV1, would then the ratio be increased?
The
Or-
ratio, yeah, might be somewhat increased,
Okay.
but it's usually, it's usually fairly close.
Mhm.
All righty. Anything else? So that's how we subclassify major pulmonary diseases. Either we subclassify it as a restrictive lung disease or some sort of obstructive lung disease.
So the FEV1 is there in, and the other one,
Take a deep breath. Slow. All the way that you expelled in the first second. That's the FEV.
and then the other one is the one in.
Yeah, take a deep breath and exhale for as long as you can. No time restriction. All right. Any other questions on that?
How are you measuring? Or how is it?
You can measure that with a spirometer. Yeah, take a deep breath, blow. You just measure the amount of volume that was expelled in the first second. Usually you're plotting change of volume as a function of time. Anything else? Okay then. Let's talk about a few different types of generalities. Let's first talk about some of the obstructive lung diseases. Okay, obstructive lung disease, we said characterized by a reduction in the FEV1. The FEV1 or FVC ratios can be clearly reduced. Okay, best characteristics of an obstructive lung disease. Now, we can subclassify obstructive lung diseases into acute and chronic forms, depending upon the timing in which the FEV1 changed. Typically, acute obstructive lung disease characterized by a rapid but reversible drop in the FEV1. Okay, if someone has a acute obstructive lung disease, typically the FEV1 is normal. Something happens, there's a quick reduction in the FEV1, but the reduction is transient, it usually returns to normal. That's an acute obstructive lung disease. Chronic obstructive lung diseases are different. Usually a chronic obstructive lung disease is characterized by an insidious but permanent reduction in the FEV1. It drops very slowly over time. We describe that to be insidious, but it's irreversible. The reduction is permanent. You don't get it back. Those are examples of chronic obstructive lung diseases. Okay. Any questions on that? Let's take a look at some examples of the obstructive lung diseases. We're going to take a look at an example of an acute obstructive lung disease. First, we're going to take a look at asthma. Okay, asthma is a good example of an acute obstructive lung disease. Asthma is a condition in which the airways of the individual are chronically inflamed, and they're very irritable. When they're very irritable, sometimes they will go into a spasm and will clamp down. Now, normally, of course, the airway is nice and patent, but when it's chronically inflamed, sometimes one more additional irritant will cause the airway to clamp down. It becomes very difficult to exchange air, very difficult to ventilate the lungs. Typically, it's easier for the person to inhale air than it is to exhale air. And so during an asthmatic attack, during the time when these airways are clamping down, people tend to hyperinflate their lungs. They tend to be able to inhale the air, but they can't really exhale the air. It's very difficult. If they try to exhale, you'll see a significant and quick reduction in the FEV1. And all of this is caused by these very hyperreactive airways because they're chronically inflamed. Now, we're going to talk a little bit about the inflammation. The inflammation is specifically characterized by a lot of different types of inflammatory cells, but the most prominent of these inflammatory cells is the eosinophil. Eosinophil characterizes a large fraction of the inflammatory cell infiltrate that chronically inflames the different airways. And that makes them very, very sensitive to any kind of stimuli. They can go into a spasm. Okay, let's talk about the two types of asthma. Okay, both types of asthma involve these hyperreactive areas that can clamp down into a spasm, make it very difficult to exchange air. The asthma can be subdivided into two major types. We've got the extrinsic asthma, and then we've got intrinsic asthma. Most important thing for you to remember about extrinsic asthma, usually pediatric population, young people, very young people. Most important, young people. Second thing to realize, it is triggered by a type 1 hypersensitivity reaction. A type 1 hypersensitivity reaction. I'll show you what that is in a minute. Extrinsic asthma, young people, immunologic trigger, type 1 hypersensitivity reaction. It's usually caused by inhalation of antigens to which an individual is sensitive. Type 1, then that triggers a type 1 hypersensitivity reaction. The other type of asthma is called intrinsic asthma. Intrinsic asthma usually affects adults. Doesn't typically affect younger people. It affects adults. It has a non-immunologic trigger, It's usually caused by something that results in an imbalance between bronchodilators and bronchoconstrictors, favoring bronchoconstriction. Airways are irritable. Something affects the balance between bronchodilators and bronchoconstrictors, tipping in favor of the bronchoconstrictors. The airways go into a spasm. That's intrinsic asthma. Okay. Adults, non-immunologic trigger. All right, let's talk about each one of these. Let's first talk about the extrinsic asthma. As I said, extrinsic asthma typically affects younger people in pediatric range, and it has an immunologic trigger. A type 1 hypersensitivity reaction triggers this asthmatic attack. Let's take a look at the different types of hypersensitivity reactions. We have a nice graphical depiction of these different types of hypersensitivity reactions here. We got the type 1 reaction shown here. Type 1 reaction is mediated by mast cell degranulation. Typically, you've got this mast cell sitting in the respiratory system. It's loaded with histamine. And histamine is a bronchoconstrictor. Remember, bronchoconstrictor, okay? On top of the plasma membrane of the mast cell, you've got this immunoglobulin of the IgE family. And those immunoglobulins are kind of sticking out, doing nothing wrong. However, if the individual inhales an antigen to which they're sensitive, the antigen is going to cross-link the immunoglobulin and cause the mast cell to degranulate. And it's going to spill histamine on this very irritable respiratory airway. And that's going to cause the airway to go into a spasm. And a result, the person's going to develop an asthmatic attack. It's going to clamp down. They're going to have a sudden drop in the FEV1. And until they're treated, or until they get resolve it themselves, the FEV1 is going to be depressed, and then it'll return back to normal. Take a look at this. Here's an example of a section through the respiratory tract showing you one of these mast cells. There's the airway right there. We have the respiratory epithelium right there. You can see the stratified ciliated epithelium here. This is the pseudostratified ciliated cell. You got some goblet cells here. That makes up the respiratory epithelium. You got a basement membrane running underneath. Underneath the basement membrane, you got the subepithelial tissues. And in the subepithelial tissues, you see that. That is a big mast cell. And you'll notice the mast cell has a lot of basophilic granules in its cytoplasm. Each one of those contains, amongst other things, histamine. As long as the histamine stays sequestered, it's not going to cause bronchoconstriction. But you dump that on a hypersensitive airway, the airway is going to go into a spasm, causing an asthmatic attack. Let's take a closer look at that mast cell. I think I showed you this before. This is a transmission electron micrograph of the mast cell. This is the cell that mediates the type 1 hypersensitivity reaction that triggers the asthmatic attack. Nucleus, cytoplasm, some connective tissue out here, very electron dense granules, all of which containing things like histamine. Now, very often people with extrinsic asthma have sensitivity to some common types of antigens. It seems that most extrinsic asthmatic patients have a sensitivity to some common types of antigens that they're exposed to. Here are some common ones. Common extrinsic asthmatic triggers. Of course, we have pollen. Okay. A lot of different types of pollen will trigger things. We've got the dust mites, specifically the fecal excrement of the dust mites is very antigenic and can trigger an asthmatic attack. Mold, the different spores of mold, different chlamydia that they produce. And of course, we got some pet dander. Cats especially, it's actually the saliva proteins on the cat dander that tend to be antigenic and trigger an asthmatic attack. Any questions about extrinsic asthma? Okay, let's talk a little then about intrinsic asthma. Okay, again, remember, adults, non-immunologic trigger. This asthmatic attack is typically caused by some sort of imbalance in dilators and bronchoconstrictors. These individuals also have very sensitive airways, but the mechanism which triggers the asthmatic attack has nothing to do with IgE, nothing to do with mast cells at all. Just an imbalance in constrictors and bronchodilators. Typically, they have these chronically inflamed airways. Something else happens. For example, they take aspirin, or they have superimposed on their chronically inflamed airways some sort of viral infection, and that's enough to tip the airways into bronchoconstriction. You go into a spasm. Now, asthma is a big offender for a lot of the people with intrinsic asthma. Can you tell me what the mechanism for aspirin would be? What do you think the mechanism would be for aspirin to trigger an intrinsic asthmatic attack? Blocks the COX pathway, and that results in a failure to produce things like prostaglandins. Prostaglandins are bronchodilators. And so if you stop the production of the bronchodilators, now you tip things in favor of constriction, the airway goes into a spasm. Okay. So aspirin's a big offender. Various pulmonary infections, especially viral infections superimposed on an already inflamed airway, person's gonna possibly have an intrinsic asthmatic attack, also stress. Okay, and sometimes exercise can trigger an intrinsic asthmatic attack, exercise-induced asthma. Okay. All right, pathogenesis. All these different types of asthmas have the same pathogenesis, chronically inflamed, hypersensitive airways. Now, these airways are always inflamed. There are lots of different types of inflammatory cells that comprise the inflammatory infiltrate of the airways. But there's one cell in particular that you see in asthma that you don't see in a lot of other diseases that involve chronic inflammation of the airways, and that's the eosinophil. Eosinophil plays a key role in the pathogenesis of asthma. Now, people's airways are chronically inflamed. They make a lot of mucus. And so because the airways are constantly inflamed, they have that chronic cough, which may or may not be productive of mucus. The airways are filled with a lot of mucopurulent plugs that sometimes cause atelectasis. Let's take a look. Here is a section through the airway of an asthmatic, and you can see the lumen of the airway there. There is the wall of the airway. This is supposed to be the respiratory epithelium. While you do have some pseudostratified ciliated cells, a lot of these cells are goblet cells. The inflammation tends to cause goblet cell hyperplasia, and you get a little alteration of proportion of different cell types in the respiratory epithelium. And there's the rest of the wall right here. And you can see some alveoli out over here. Within the lumen of the airway, you can see that. That's a mucopurulent plug. It's basically mucus with a lot of inflammatory cells. That's a mucopurulent plug. Okay. And if we take a look at the different inflammatory cells, we see a lot of different types of cells, many different types of cells, and we especially see these cells with their eosinophilic cytoplasms. Those are the eosinophils. There you can see there are lots of eosinophils in the mucopurulent plug. And the eosinophil is a cell you see in this pathology that you don't see in a lot of other pathologies characterized by chronic inflammation. Chronic bronchitis, for example. Well, that's another disease causes chronic inflammation of the airways. Why doesn't that cause asthma? Because the chronic inflammatory infiltrate is not comprised of eosinophils. There are no eosinophils that characterize chronic bronchitis, or the inflammatory infiltrate of chronic bronchitis. Asthma is one of the few diseases in which you see these eosinophils. Okay. Now, often with all this chronic inflammation, the epithelium, the respiratory epithelium, kind of sloughs off. It gets damaged by this chronic inflammation, kind of curls up and makes these stringy spirals that you see. And here's an example of a sample of these little spirals that are made by this desquamated respiratory epithelium, kind of curls up, a lot of debris, and make all these little curly spirals here. These are called Kirschmann spirals. They're just aggregates of material that have kind of eroded from the respiratory wall, kind of mixed in with a lot of things. Even those little, yes.
Is the eosinophils only in the extrinsic asthma, or
See them in both.
You see them in both. Okay.
So
That's a good question.
they are present in the chronic?
What?
The eosinophils are present or not on the chronic? I thought you said not present.
The eosinophils are present in that chronic inflammatory cell infiltrate that characterizes asthma. So anyone with asthma, their airways are inflamed. If you sampled that infiltrate, it would contain eosinophils. Yes. Okay, Nick, you see Kirschmann spirals. That's just that desquamated material. Okay. Any questions on that? Okay. Let's have a look at some of the changes that occur in the airway as a result of being chronically inflamed. Now, these airways are chronically inflamed. There are going to be some architectural changes in the airway as a result of the chronicity of the inflammation. Let's take a look at that. Okay, here are sections or depictions of sections through these airways. So here's a normal gross appearance of an airway. You can see it's got a nice patent lumen and it's got a very sturdy wall. Okay, that wall will remain patent during both inhalation and exhalation phases of the respiratory cycle. Asthmatic has chronically inflamed airways. Okay, and as a result of being chronically inflamed, they're going to be kind of thickened as a result of edema and other changes in the wall architecture. The lumen consequently is a little bit smaller. In addition, because of all that inflammation, you have a lot of mucus that begins to accumulate in the lumen of these airways. Let's take a look at what happens microscopically. Let's first take a look at the depiction of a normal airway. This normal airway architecture. There's the lumen, there's the wall. Okay. First layer you see here is the epithelium. Again, that's normally a pseudostratified ciliate epithelium. It's coated with a very thin layer of fluidic mucus. Okay. Sits on a thin basement membrane. Below that, you have the lamina propria. Lamina propria is this vascularized layer. You typically see some inflammatory cells in that lamina propria, in that vascularized layer. They're basically just part of the normal physiologic inflammation. And they're acting as sentinel cells. Make sure that none of the microbes that we inhale are going to invade our lungs. Okay, they're sitting right there. Underneath that, you have the smooth muscle, okay, that controls the caliber of the airway. Remember, collectively, this layer, epithelium, the lamina propria, and the smooth muscle layer here, muscularis mucosa, is referred to as the, what do you call these three layers? Epithelium, lamina propria, muscularis mucosa. What if I told you this is the submucosa? That's the mucosa up there. So collectively, these three layers are referred to as the mucosa. Okay, everything looks good there. Now you got the submucosa, you got submucosal glands, and of course you got the supportive architectural cartilage there. Okay, that's normal. Here is a depiction of the inflamed, chronically inflamed airway of an asthmatic. And the first thing you notice is the wall is thicker compared to normal. That's due not only to the edema of the inflammation, but the chronicity of the disease causing architectural changes. We call them the changes of chronicity. Okay, take a look at it. The airway, lots of mucus, lots of different inflammatory cells, but especially, look at that one, the eosinophil. Okay, eosinophil is in there. This stuff makes up the mucopurulent plugs that you see in the airways of asthmatics. And asthmatics typically have parts of their lungs become atelectatic as a result of some mucopurulent plugs developing in the airways. It's usually not a big problem, but they do have some segments of their lungs remarkable for atelectasis. Okay, we have in the respiratory epithelium itself, goblet hyperplasia. You still have the pseudostratified ciliate epithelium, but you have a greater proportion of goblet cells because of the inflammation. So that's an example of goblet cell hyperplasia. All that sits on a basement membrane. The basement membrane is thicker because of the chronic inflammation. It's not quite as thin as it normally should be. Look at the lamina propria. It's filled with a lot of different inflammatory cells. Again, all types, lymphocytes, neutrophils, mast cells, macrophages, and that one that you should associate with asthma, the eosinophil. Blood vessels engorged with blood, okay? Smooth muscle layer, very thick, very hypertrophic. Change of chronicity. And again, you see lots of these submucosal glands that are both hyperplastic as well as hypertrophic. Okay, you've got a lot of different submucosal glands there again because of the chronic inflammation. These are the changes of chronicity of the disease, the longevity of the disease, protracted nature of the disease, causes changes in the architecture of the airway, makes the airway thick, and also makes it produce a lot of mucus. And so even when these individuals with asthma are not having an acute asthmatic attack, they do have some degree of chronic obstruction. The airway is a little bit more narrow. It's usually, again, not a problem when they're not having an asthmatic attack. But if you actually measure air flow in an individual with asthma, even when they're not having an asthmatic attack, they're not quite normal. They don't have a quite normal FEV1. But again, that's not the major problem with this disease. Major problem is during the acute attacks. And so we classify it as an acute obstructive pulmonary disease. Okay. Any questions there? Let's talk a little bit about the management of this. And you don't have to know this, but if you're curious how we manage asthma, you probably already know we use some sort of inhaler. Okay, this inhaler is a beta adrenergic agonist. Beta adrenergic agonists cause bronchodilation, and so if the problem with the airway is going into a constriction, it's clamping down hard. You want to relax the airway. The only known way to abort an acute asthmatic attack is to use some sort of beta adrenergic agonist. Typically, we deliver it to the airways using some sort of nebulizer. Very often, the beta adrenergic agonist we use is albuterol. Sometimes we use a different form, a really high form of albuterol. Some people have trouble with albuterol; they develop tachycardia. So we give like levalbuterol. Generally achieves the same thing, but it has fewer side effects, including tachycardia. Any questions on that? Asthma? Okay, let's introduce you to the next disease. Maybe you won't get into it, but we'll just introduce you to it. That asthma is an example of an acute obstructive disease. Remember, what characterizes acute obstructive disease? There's a reduction in FEV1 like all obstructive diseases, except it's an acute obstructive disease, which means there is a very quick but transient reduction in the FEV1. As soon as the asthmatic attack is over, the FEV1 more or less will return to normal. That's in contrast to the chronic obstructive pulmonary diseases. Chronic obstructive pulmonary diseases, there is an insidious reduction in the FEV1. The FEV1 drops slowly over time, and it is not transient. It's irreversible. Whatever's causing the reduction in the FEV1 is permanent damage. And so chronic obstructive pulmonary diseases are characterized by insidious but irreversible drop in the FEV1. Now we're going to talk about two of these. Two good examples of a chronic obstructive pulmonary disease would be emphysema and chronic bronchitis. Very often, these two diseases, emphysema and chronic bronchitis, coexist in an individual patient. And that's because they often have the same etiology. The most common cause of emphysema is cigarette smoking. And the most common cause of chronic bronchitis is cigarette smoking. So very often, when one person has emphysema, they also have chronic bronchitis and vice versa. Okay? They all have the same etiology. Okay. Any questions on any of that?
Doc, is that the same for smoking weed?
Smoking weed.
Ah, yes,
What
the
is
weeds. Yes,
What
the
is this
weed.
smoking of weed you talk about?
I don't know.
Let's find out.
I was always,
Let's do a
so I
study.
had, I had roommates that smoked all day, every day. And at the time, I was a cigarette smoker and I would get bronchitis all the friggin' time. No doctor, they couldn't talk to me at 22 and tell me stop smoking. I would listen, but these other guys, they smoke weed all day and they're fine. Just didn't get it.
I think it does. I read a few things. I can't reference this, it's been a long time, but I think it does the same.
I can imagine that there's some products in there that can irritate. But I don't know.
All
how
natural.
What about vaping?
From what I understand.
Vaping
it's
kills you
more
on
about,
sight.
like the toxins in a cigarette than it is about the smoke itself. So the smoke obviously causes some type of damage, but it's more so the chemicals that are in a cigarette. Weed tends to be a little bit better when it comes to the chemicals in crop that are in it, it's slightly more natural.
Not mine, I
I think
lace
it
it.
still has some.
These were natural cigarettes I plucked from the earth
It's
myself.
not just a cigarette.
Sprinkle more drugs on
Ultimately,
top of the weed.
cigarettes cause things like emphysema by inhibiting an enzyme called anti-elastase. And it increases the activity of elastase. And so ultimately, the mechanism for developing emphysema is an increase overall of elastase activity. And cigarette smoking achieves that through different methods. And I guess we'll talk about them next time.
I gave it to you.
Okay,
All right.
anything else?
Wait, what did you say that enzyme was?
Anti.
Elastase, There's an
elastase.
increase in elastase activity.
Elastase.
Okay. All right.
Elastase.
In that case, we will call it a day.
Thanks, Dr. Meddy.
Okay, well, 17 minutes.